So now I'd like to invite Dr. D. Ramamurthy, sir, a brilliant surgeon, great academician. He would be speaking to us on clinical performance of next-gen Toric IOL. Dr. Virendra Agarwal, sir, please load your.
Thank you, Anaga, and thank you, panel. I'm going to be speaking on clinical features of the next-generation Toric IOLs. I think all of us understand that to leverage the full potential of the toric and intraocular lenses, accurate alignment of these lenses is extremely important. You might have reservations about multifocal lenses, trifocals, EDOF, etc. But toric has come to stay, and at least 40% of my patients do get a toric intraocular lens. And we all understand that any significant deviation from the intended axis causes a deterioration in the quality of outcomes. Every 1 degree deviation causes a 3.3% reduction. It is said that more than 5 degrees of deviation is a matter of concern. If it's more than 10 degrees, it's a surgical intervention is most often needed. The primary toricity is also important because if you have a 4.5 diopters of toricity, even a couple of diopters of deviation might cause a significant problem. One thing we need to understand is that when we talk about stability of toric intraocular lenses, we are most concerned about the stability of the toric intraocular lenses in the first 1 hour. Because most often, irrespective of the quality of toric intraocular lens that you're using, they remain stable 1 hour post-operatively. IOL rotation after 1 day post-operatively is less than 1%. So essentially, the important idea is to get the lens right there exactly in position and ensure that it stays in position in the first 1 hour. And that if you see the Toric 1 and the Toric 2 intraocular lenses from the Johnson & Johnson platform, they're exactly the same, but the Toric 2 is said to perform somewhat better as far as stability of these lenses is concerned. It's simply because there is a difference in the haptics, and while a Toric 1 has a smooth finish, the Toric 2 has a frosted finish like this. And it is just a very simple manufacturing process. All these lenses are tumble polished. It was earlier, the optics and the haptics was tumble polished. But now what they have done is to introduce a small sleeve onto the haptics. So the haptics doesn't get polished and it's only the optics get polished. So the roughness remains. And because of this roughness of the haptics, there is greater ability to be rotationally stable because of the adherence to the fornices of the capsular bag. And this has significantly enhanced the outcomes as far as these intraocular lenses is concerned. And another byproduct of this is that, the PMMA lenses stick, the haptics stick to the optics the least, then the hydrophilic. The hydrophobic, all of us know the tackiness of the material has its advantages, but there is also a tendency for the haptic to stick to the optic very strongly. Because of this roughening up of the haptics, the tendency to stick to the optics is gone, and now it unfolds much faster. It said that the difference is about 0.25 seconds on an average, and faster adherence to the capsular fornices again potentiates to greater stability of these lenses. This is a very short video of the intraocular lens. All of you have seen this, though you might not have noticed the haptics. You can see the frosted haptics in this, which is very clearly seen. And once you introduce this through your preferred technique, usually 2.2, 2.4 millimeter, you can also see that it very quickly unfolds and you are able to implant the lens exactly in the axis that you need, and that makes the lens remain stable. And 1 week post-operative mean residual error, a large study showed that a mean manifest cylinder for all eyes was less than 0.30 diopters. 84% of the eyes were within 0.5 diopters of intended cylinder, while 98.5% were within the intended dioptric power of 1 diopter, cylindrical residual power of 1 diopter. And an even more important thing is that when you are talking about highly myopic eyes which have obviously larger bags, the stability of these lenses does not change, and that's a very major plus point as far as the post-operative benefits are concerned. This is not just confined to the torics from the J&J platform. Even the Vivinex toric, which was alluded to just now, has a similar effect in which both the haptic surface, the anterior and the posterior sides as well as the edges have this frosted or the roughening, because of which there is enhanced stability. Actually, the Vivinex came up with this much before the Johnson & Johnson did this. Just because the Toric 1 from the Johnson & Johnsons were not so stable, they had a potentiation to rotate almost 3 times as much as the Alcon Torics. They came up with this modification because the stability of these lenses is much better. This is just to show you a Vivinex toric being implanted. As you can see, again, the roughened haptics. All of us have used these lenses, and this is just to show you the roughened haptics, and subsequently the propensity to stick to the optics is also much less, and greater approximation to the capsule of fornices and greater stability. The other important modification that is there, which has been around for a long time, is the design of the haptics per se. All of us know about the AIOCMT3 lenses coming with the stable force haptics. What exactly does it mean? It acts something like a finger with 3 folds. And in case you have a large bag, there is only 2 folds over there. There's a greater approximation. If it is shorter bag, say a 10 millimeter overall diameter bag, then it folds up like this because the approximation is there. And that's the reason these lenses are supposed to be quite stable. Another important factor is the stickiness of the material. And though all hydrophobic materials are supposed to be quite sticky, there is a differentiation between the different platforms. And the greater the stickiness, the AIOCMT material as well as the IOCare material is supposed to be significantly better in this aspect, because of which the ability to stick to the optics is there. In 2022-23, these are the toric lenses that I used, and you can see the AIOCMT IQ toric 615, Hoya toric 2265, and Technis 2 toric 417. The numbers were not so good when it was Technis 1. As you can see, all these lenses performed quite well, but they had to rotate these lenses 2.27% the eyes in IQ toric, 0.7% in Hoya toric, and none in Technis toric. It's a combination of circumstances that help. So essentially, to summarize, accurate alignment of toric and intraocular lenses is paramount importance, and we all need to understand that what we leave the patient behind on the table is most often what the patient stays with, because once you get the lens stable for the first 1 hour, that's the reason that we always patch these eyes post-operatively and remove the patch a couple of hours later. The lens remains quite stable. Frosted haptics mitigates this because of greater friction between the haptics and the capsule of fornices. Design of the IOL, like the stable force haptics, is an additional factor, and stickiness, the hydrophobic material, also helps. Thank you so much for your kind attention.
Yeah, thank you so much, sir. So, one more point was the Rayner EMV Toric. That has the greatest contact angle if you compare the contact angle with the other lenses. How important is that? And it has the 360-degree Amon apple edge also, which helps in better rotational stability. What is your...
Yeah, I think that's an important point. You know, it's not only the flexibility of the haptics, like is the stable force haptics, is also important, because you get capsular sizes right from 10 millimeters to 12.5 millimeters. And the haptics being flexible so that it can either shrink down or expand, at the same time being also rough, is obviously advantageous. So the reason I cover different platforms is different platforms have certain advantages. Maybe the lens of the future should have a combination of all of this.
Yeah, so we should actually give them this idea that so each has different advantages, but there's no one lens that has everything.
Dr. Ramamurthy, what about the Alcon? You said that you found more rotation with the Alcon lenses compared to the others. Although it's a very tacky material, and we have found that almost we have the least rotation in Alcon lenses, provided you remove your viscoelastic very well. So
Absolutely.
What do you feel about that? Because although these have a rough edge, but still the tacky material also makes a very important difference.
Absolutely. Actually, you know that there was a very significant study from David Chang which showed that the rotational stability of the Alcon torics is 3 times better than the toric one from the J&J. And that is the reason actually J&J went back, and then they did not alter the shape of the haptics, but they introduced the roughness of the haptics, because of which it was good. Even in my study, if you see, it was just 2.2% where I had to rotate these. That is, out of more than 600 eyes, 14 of them I had to rotate, which is per se a small number. But then going forward, I think even this can be brought down.
Also, Hoya came out with an overall diameter of 12.5 earlier, and then had to switch over to 13 millimeter diameter with the roughened edge to give it more stability.
Right.
So how many of the panelists see the patient again after 1 or 2 hours?
I
So I mean, all of us believe and agree that it rotates in the first 1 hour, but how many of us actually do it?
No, I don't check for rotational stability and all that. What we do is obviously most of us do under topical anesthesia and we don't patch the eyes. But toric intraocular lenses, toric monofocal or multifocal, I always patch the eye. And once the patient has been in all instructions is going home, about an hour or two later, either me or one of my colleagues takes off the patch and sends them.
So what we do in our practice is not only torics, but for all patients, we do refraction the next day immediately. First day post-op. So I see the patient with full refraction. So if you see that there is a residual astigmatism, then you know that probably the lens has rotated. Then I dilate immediately at that point of time and see if it has rotated, then we go back and rotate it. We don't wait for a week or so to do.
Anaga, there has to be a set, protocol, which are those cases where rotation would be needed. You can't really jump on every patient to rotation because criteria has to be set. So one of the criteria will be visual acuity of a patient. Second is the degree of rotation. Third is the anatomical configuration. If the patient has a myopic, big bag, loose bag, shallow chamber, any other associated problem, maybe a leaky wound, something, those has to be assessed before we think of rotation.
Yes, absolutely.
If my patient is happy with the, even if there's a 10-degree rotation, patient has a better than 6-9 vision, patient says, I'm okay, why should we rotate? If patient has, I put a multifocal toric lens, patient has 6 past vision, but not happy. So I may have to consider rotation that despite having a 5-degree rotation. So each patient has to be assessed thoroughly, then judged. There's no requirement for immediate rotation in these cases. You can wait for a few days, a week also, because sometimes lens sets in the proper position also. To assess the case properly, then decide what is to be done.
The sweet spot for the rotation period is supposed to be 2 weeks, when the capsule is slightly fibrous and likely to remain.
Another point I want to add that always check on the slit lamp the axis is actually implanted axis or not.
Yes,
because
absolutely.
there can be surgery induced astigmatism particularly on the day one because of the incision.
Yes.
So don't do probably on first day.
No, we just see on first day, but then final rotation we go ahead and do after 1 or 2 weeks only. But at least we can follow up the patient properly.
Then we know
we have some idea what is happening.
I think as Professor Tejal said, you should analyze the satisfaction of the patient. In the sense the patient is very happy, satisfied. Why do you suggest that you got a little, you need a minor rotation and then put it into his head that he's got a lens which has got rotated a bit and then he doesn't know what is the rotation and he feels that something is very grossly gone wrong with his eye.
I think sir, 1 or 2 instances I had to do immediate rotation as Dr. Anaga said in day one, because by mistake, sometimes your orientation is distorted by your assistant. You would say rather than 180, I put it 90 degrees. And that is an indication to rotate immediately.
Yes.
Or by mistake, there were 2 patients lying up and you exchanged the lenses. It has happened to me once or twice. That I had to take the patient, both the patient there and change the lenses for them. Those mistakes can happen. Therefore, it is important for us to assess your patient on the table also. Check the power, check the axis, same patient, then implant. But especially when you have a larger number of cases piled up, you can have these mistakes also.
Any experience with Indian Toric?
Yeah, I do use
I use a lot of Indian
also.
torics.
Especially IOCMT3.
Care group
They do
and
wonderfully well.
very well.
Wonderfully well. Even their trifocal lenses are so good.
Yes, absolutely.
Yeah, exactly, you're right.
No, that was what I was alluding to. There is even a small experiment done when these lenses have been placed on a petri dish and you have a flush of water. The Acrisoft lens and the Acryol lenses tend to move much less than some of the other lenses. That shows the